Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Kevin Bronson-Castain, RN, PhD. Kevin Bronson-Castain graduated from the nursing program at the University of California, San Francisco School of Nursing. He received a Bachelor's of Science degree in psychology at the University of Washington. Kevin received his PhD in vision science and is a clinical diabetes researcher at the University of California, Berkeley. Kevin is a registered nurse at the Washington Hospital Healthcare System and an assistant researcher at the University of California, Berkeley.
I originally got my doctorate degree at UC Berkeley, and I did my postdoctoral work there as well. And we looked at diabetic eye disease, and we looked at trying to detect it as early as possible. And I'm going to talk a little bit more about it as we go through the talk. That led me into nursing. And with nursing, I actually get to incorporate some of the things that we learn in research and hopefully improve your care. So we'll talk a little bit about how diabetes has changed. Diabetes research has changed and how we're dealing with diabetes, why it's important. We'll talk about some of the statistics about diabetes. We'll go over the goal of diabetes research. We'll talk about a little bit of history. It's important to know where we've come from. We'll talk about some of the current diabetes research that's going on and how it's affecting our diabetes management. I'll talk about some research opportunities here in the Bay Area and give you a little bit of education around participating in research. And then I think we'll call it a night or answer your questions at the end. So before we get going too far, we kind of need to all be on the same page. I know most of you probably had some education around diabetes, but I'm going to give a brief review. So here's the human body here. We've got the heart, the lungs, the stomach, and down here we have an organ called the pancreas. And the pancreas is an important player in diabetes. So as we eat food, it comes down the esophagus, it ends up here in the stomach, and it starts to get broken down into components that we can use, that our body can use as energy and fuel. The pancreas actually participates in that. It participates in breaking down that food, but it also produces some hormones that are really key that allow us to use that fuel as energy. And our body is incredibly dependent on glucose, sugar. Okay, we'll talk a little bit more about that in a minute. So here we've got the beating heart. It's distributing blood throughout the body. And then imagine that we're taking in food. Okay, it's being broken down in the stomach. And as the sugar is getting broken down, it's being absorbed into the bloodstream here. Okay, it'll play again. And as the sugar is absorbed into the bloodstream, the pancreas is actually releasing a hormone called insulin. And that insulin is important for taking that sugar out of the blood here and actually moving it into the cells where it can work and do its job. So in type 1 diabetes, I won't talk a whole lot about type 1 diabetes. Type 2 is the big topic tonight. And in type 1 diabetes, our immune system actually attacks some of the cells that live in the pancreas. And these cells are called beta cells. And they live in the islands of Langerhans. Okay? And for our immune system, its job is to prevent infection, bacteria, viral. Well, with type 1 diabetes, it makes a mistake and actually identifies these cells, these beta cells in the pancreas, as foreign, and it kind of knocks those beta cells out. So the pancreas isn't able to produce any insulin at all, okay? And we are dependent upon insulin. Insulin, without it, we can't survive, okay? That's the key to getting the sugar out of the blood and into the cells where it can do its job. So with type 1 diabetes, we're actually dependent upon insulin from outside, okay? They have to have insulin to survive, and so they have to give injections of it. We also have type 2 diabetes that also requires some insulin as well. Now with type 2 diabetes, it's a little bit different. We still have the stomach here, we have the pancreas. In type 1 diabetes, we actually can't produce this insulin here. But in type 2, at least in the initial stages, our body's breaking down the glucose, it's getting absorbed into the blood system, and our body is actually able to produce insulin and put it in the bloodstream as well. But the insulin that we're producing isn't working the way it should, okay? It's called insulin insensitivity. So the insulin is out there, and that's the key to opening up the cell, but for whatever reason, and there's multiple reasons, it's not able to open up that cell, so that sugar can't get out of the blood and into the cell where it can do its job. So in both type 1 and type 2 diabetes, we end up with too much sugar in our blood, okay? If you have diabetes, you know this, so we check our blood sugar, and what we're measuring is how much sugar is in our blood, okay? And the goal is to keep it at a normal level. In type 2 diabetes, here's a normal patient, a normal situation here. Again, our stomach is absorbing glucose, and our pancreas is producing insulin. The insulin is working on the cells, in the muscle cells. It's also working on the liver to take in that sugar and store it as energy for later use. Well, with type 2, for whatever reason, this insulin doesn't work as well, and so we can't utilize that sugar. Another key term that we need to introduce here, because we're going to talk a lot about it as we go through the talk, is your hemoglobin A1C. Some of you may know what this is, others may not. But in our blood, we have red blood cells, and these red blood cells are pretty important. They deliver oxygen and other nutrients throughout the body. And they live inside of our body for 2 to 3 months, and that's important. As they flow around the body, they actually collect things, and one of the things that they collect is sugar, okay? So during the lifespan of a red blood cell, they collect this sugar. We can actually measure how much sugar is attached to these red blood cells. And we can actually get a measurement of what your average blood sugar was over that lifespan of that red blood cell. So with our A1C, and the goal is to keep it less than 7, and let's just say we have an A1C of 7 here. Our average blood glucose over the last 2 to 3 months was 155. Okay? So it's an important measurement both for the clinician but also for those that actually have diabetes. Because this kind of tells us how effective our treatment is, not on a day-to-day basis, but over a long time span. Okay? We know diabetes is a big problem. It gets lots of press. And if you're here, you know that diabetes is a problem. We have about 26 million people in the United States. It's about 8.3% of the population that has diabetes. But that number is a little bit misleading. If we look as the age groups advance, if we look at the age group of 45 to 64, actually 13, almost 14% of the population, of that population has diabetes. But then if we go over 64, almost 1 in 4, over 1 in 4 people have diabetes. So it's really impacting our older population. So it's super important. We're actually also seeing it in early childhood. We've seen an epidemic of obesity and type 2 diabetes in the United States. And as it's happened with our adults, it's also happened in our children as well. I won't go into too much more detail with that. And we see it everywhere. We see it on the news. We see commercials advertising our diabetes products. First Lady Obama, she has an ambitious program to actually work with children to get them out there and get them more exercise to reduce that rate of diabetes, obesity as well as diabetes in the young, getting at these problems really early. And we actually even have, here's an aisle at a CVS, I think it is. We actually have dedicated aisles to our diabetes care. So it's a big issue that we're spending lots of money on it. So, glucose. Sometimes when we talk about diabetes, people think glucose or blood sugar or sugar itself is a bad thing. It actually is our friend. We actually need it in order to survive. But with all things, they need limits, okay? And with the glucose, we need those limits. We'll talk about why that's important. With diabetes, often comes this ball and chain. They have friends, and these aren't good friends to have. Okay? With diabetes, we tend to see 80 to 85% of the diabetic population there are overweight. Okay? Hypertension, we see lots of high blood pressure in our diabetic population. Too much fat in the blood, hyperlipidemia. With all of these becomes inflammation, and that inflammation can cause cell damage. Okay? These are all associated with diabetes. So why is diabetes research important? There's lots of complications that come along with diabetes. And it affects the body from head to toe. And we'll start at the head and work our way down to the toes. But it is a big component of stroke. Here we have the brain, and we've got these blood vessels that supply the brain with oxygen and nutrients. With diabetes, we often get atherosclerosis, or a buildup of fatty deposits in our blood vessels, and this can cause a clot to form, and actually a blockage which can starve tissue of oxygen and nutrients. And that's one of the leading causes of stroke. With diabetes, you actually have a 2 to 6% you're 2 to 6 times more likely to have a stroke than those without diabetes. So stroke is something, an important factor that we want to minimize the chances of having. We can also actually have a rupture too from those blood vessels. So it also affects the eyes. Diabetes is the leading cause of blindness in the United States, especially in the working age population. When we look at the eyes, in the very back part of the eye, and we'll go into more detail a little bit later, there's these very small blood vessels that come through and feed the tissue. They feed this neural tissue. And as the disease progresses, we actually see damage to those blood vessels. And those blood vessels can leak. You can see small little dots and little white specks here on the back of the eye. And that's leaking fluid from these blood vessels, and that interferes with our normal function. In this situation here, we actually have a fairly large leak on the back of the eye. So with diabetes research, and especially with eye disease, we're trying to prevent some of these kind of complications. It affects the heart. You're at greater risk for having a heart attack with diabetes for several reasons. Again, we talk about the cholesterol plaque in the blood vessels, and we are at greater risk for having a clot. When those blood vessels get clotted, we get a lack of perfusion of blood to tissue. And if we don't get the nutrients and the energy that we need, that tissue will die. Okay? Especially the heart and the brain both are very dependent upon oxygen and glucose in order to function. So it also affects the kidneys. It's the leading cause of kidney damage, transplants, renal dysfunction. In the kidneys, these kind of bean-shaped organs, there's actually, again, small blood vessels. And these blood vessels, as the disease progresses, start to leak. You can think of the kidneys as kind of the coffee filter. Okay? You want certain things to pass and other things not to pass. One of the problems with diabetes is it can cause holes to develop in that coffee filter. So we start to allow things to pass we don't want to pass. And it disrupts the normal function of our body. So that's one of the problems with diabetes and kidney disease. Diabetes can also affect our nerves. And when we have a nerve damage, it affects almost everything in our body. And one of the things it can affect is actually our intestinal tract. And it can start to slow things down. We can see blockages, constipation, things like that with diabetes. In this slide here, we actually have a kind of a cross-section of tissue. And I'll identify what these are. Here is an artery. Those are the blood vessels that take blood away from the heart. Here's a vein, and that's the vessel that brings blood back to the heart. And then right here is the nerve. And these three objects in our body kind of go hand in hand. Okay? So when we have damage to our blood vessels, we have damage to our nervous tissue. And if we have damage to our nervous tissue, it affects the health of our blood vessels as well. So one of the problems with diabetes is a diabetic neuropathy, as well as vascular problems as well. We also have problems with our sex organs, our bladder. We have a greater risk of incontinence. Erectile dysfunction is also associated with diabetes. And then, as I said, we have damage to the nerves and the blood vessels, and it especially affects our peripheral blood vessels and nerves. It affects our lower extremities, like the legs and the feet especially. It can also affect the hands as well. One of the things with diabetic neuropathy is we get pain sensations in our hands or feet, or sometimes we actually lose sensation. Because we lose sensation and we have poor blood flow to our extremities, it's easy for you're getting up in the middle of the night and you're going to the bathroom and you stub your toe. With diabetic neuropathy, if you've lost sensation in your feet, let's say you have a small cut on the bottom of your foot, you don't necessarily know it's there. And how often do we sit there and pick up our feet and look at the bottom and actually do a close examination? So with diabetic neuropathy and the vascular damage, we're at greater risk for infection. So we get up the next day, we put our shoes and socks on, we go on about our day as a bacterial infection starts to develop. As this infection starts to get worse, we're at greater risk for amputation. And diabetes is one of the leading causes of lower extremity amputations. And I actually have a personal story. My dad, we actually call him Grandpa Two Toes, because he only has 2 toes left, his 2 big toes. Over the last 10 to 15 years, he's slowly lost each of his toes because of that poor circulation and that nerve damage. So it's super important, and we're going to talk about why this is important. Here we have an amputated toe, and this is a fairly mild situation. They can get much worse, and we see a lot of it in the hospital. So what are our goals? If you had diabetes education, you've seen these goals before. We want our fasting blood sugar to be between 70 and 120. And by fasting, I mean that blood sugar when we're just waking up in the morning before we eat breakfast. So we've gone all night without any food, we'll wake up. Ideally, what we want is our blood sugar to be between 70 and 120. Now after breakfast, 2 hours after our breakfast, we want that blood sugar to be less than 160. We want that hemoglobin A1C level to be less than 7. And we want to keep that blood pressure under control. We want to keep it right around 130/80. We know that, well, I'll actually get into why we want to keep that. And then our LDL. LDL is kind of our bad cholesterol. You hear about that. We want to keep that less than 100. And we'll talk about what we do know and why we want to keep those goals, and keep as close as we can to those goals. We know that if we can lower your A1C level, that average blood glucose for the 2 to 3 months, if we lower that by 1 percentage point, let's say your A1C is 8 one day, or one test, and then the next test it's 7. We know that 1% decrease will see a 40% decrease in the risk of developing eye disease, kidney disease, and nerve damage in the body. So it's super important that we work on our diabetes control because it does make a difference. We can minimize the risk of developing some of these complications. We see a 50% decrease in vision problems if we can catch problems really early. So that's why it's important to make sure we're getting our yearly eye exams. So if problems do develop on the back of the eye, we catch it early. If we have these early interventions, we can reduce the risk of blindness as we get older. Good foot care, we talked about this just a minute ago. Good foot care can reduce the risk of amputation by 45 to 85%. So making sure that we're actually in the shower or in the bathtub, taking a second to look at the bottom of our feet, or we're going to the podiatrist every year to get our feet checked. Okay, super important. Talking to our primary care physician if we're losing sensation or having pains in our lower extremities. Blood pressure. If we can control that blood pressure, we can reduce the risk of heart disease. Super important. No heart attacks. And then early detection of kidney problems and reducing our blood pressure can greatly reduce the risk of kidney damage and kidney failure. So we have lots of different reasons why we do diabetes research and why we care about it. It affects our lives. We have a quality of life issue. It affects how we live our lives. These complications are incredibly burdensome. But it's also very expensive. And money has been a big topic in the news lately, especially healthcare. And diabetes is a big cost. We spend lots of money. $174 billion a year on diabetes care alone. Now, there's a portion of that that's directly related to the costs over here in the hospital. But then there's a portion of it, about $58 billion, that's related to a lost job. You can't work, disability, and early death. So, and we're going to talk about life expectancy with diabetes and how that's changed over the last 100 years. I'm not going to spend a whole lot of time on this slide here. You have the information in your packet. But we do spend a fair good amount of money, the government does, doing diabetes research. And there's lots of different organizations that support diabetes research. We have the federal funding. A lot of that comes from the NIDDK, which is a part of the NIH, the National Institute of Health. And the NIDDK, the National Institute of Diabetes and Digestive and Kidney Diseases, it's a long name, they spend about $625 million in 2010. So they're one of the big players in diabetes research. We also have other governmental agencies that support diabetes research. We also have a lot of private nonprofit funding out there. Some of these you might have heard of, like the JDRF, the Juvenile Diabetes Research Foundation. They spend lots of money on coming up with a cure for type 1 diabetes. And there's other organizations here as well. Some of them have funded my research as well. So a little bit of history. So it's important, I think, to kind of know how far we've come in the last, especially in the last 100 years. We've come a long ways. So the earliest record of diabetes, written record, was about 1552 BC. Okay? There was an Egyptian physician, Hesi Ra, that first mentioned frequent urination. Okay, so that's the first documented case of diabetes. We know it's been around forever, but that's the first written documentation. In about 250 BC, Apollonius of Memphis came up with the term diabetes or siphon, because in the early days, and if you have diabetes, you know this, there's a lot of frequent urination is one of the symptoms. And they would see these patients with diabetes that would waste away, and they thought they were peeing their life away, basically. So that's where they came up with siphon or diabetes. In the very early days, the life expectancy wasn't good. If you were a child with diabetes, life expectancy was days, okay? Especially with type 1 diabetes. If you didn't have that insulin, your body didn't function normally. Your body couldn't use that sugar. Your body would basically starve, okay? No matter how much you ate, and that was actually one of the treatments, no matter how much you ate, your body wasn't able to use that energy, okay? And if you were older, and by this I mean patients with type 2 diabetes, you lasted a little bit longer, you normally died of complications, blindness, heart disease, stroke, those kind of situations. In 1776, Dobson kind of differentiated type 1 from type 2 diabetes. Didn't know quite why they were different, but he knew that there was two different types, and they behaved differently. In 1869, a physician, or anatomist actually, came up with these two different types of cells in the pancreas. He didn't know what they did, but they later come to find out one of those was the beta cells. And those are the beta cells that live in the islets of Langerhans, okay? The islands of Langerhans. So 1920, actually I haven't gotten there yet. So at this point here, 1897, life expectancy for a 10-year-old with diabetes was about a year. And if you made it to 30 years old, you would live maybe 4 more years. If you made it to 50 years old, you would live to be another, to 58. Okay, so we've got a little bit better at that point, but still not great. So in 1921, Banting and Best, two scientists up in Canada, up in Toronto, discovered insulin, or actually were able to isolate insulin from the pancreas of a dog. Actually, Banting was actually a podiatrist who had a very slow practice, so he got bored and decided to go in and do some diabetes research. But anyways, this was a big change in how we treated diabetes. From this point on, things get pretty exciting. So in 1922, Banting and a group of his friends actually treat Leonard Thompson here. Okay, Leonard Thompson was a 14-year-old boy. He was near death. So it was kind of a last-ditch effort, and they started treating him with insulin. And they were actually able to keep him alive until he was actually, I think, 27 years old. So they were actually taken from near death and actually prolonged his life. And that's a pretty good picture of him. So that one discovery there of insulin, being able to isolate insulin from the pancreas, made a huge difference. In 1936, Hemsworth defines insulin insensitivity, and this is super important for type 2 diabetes. So really early, we could tell. Now, so at this point in 1936, we had insulin. So we were treating all diabetics with insulins. We didn't have pills at that point. So we knew that there were some diabetics that only required a little bit of insulin, and there was others that required a lot. And so we knew that those that required a lot, those were the ones that were insulin insensitive, or type 2 diabetes. So in 1940, we discover the link between diabetes and kidney disease and blindness. By 1945, about 50 years later, our life expectancy for a 10-year-old goes up considerably. You could live to 45. A 30-year-old could live for another 30.5. He can get into his 60s. And a 50-year-old could live into his 60s. Okay? So in that 50 years, we've gone a long ways with life expectancy. We had our first blood glucose strips in 1964. Our first glucose meter that they used in the doctor's office in 1970. Our first home use meter was in 1983. It's kind of crazy. I mean, we see them all over the place now, and if you have diabetes, you know what they're like. They're pretty small, easy to use devices. Insulin pens were introduced in 1986. And then in 1993, there was a big diabetes study. It's called the DCCT, the Diabetes Control and Complications Trial. And this was primarily looking at type 1 diabetes, but we actually looked at the connection between how well we controlled our diabetes and the likelihood of developing complications. This is important. So when we have diabetes, it doesn't mean that it's inevitable that we're going to develop these complications. There's actually something that we can do. And if we can improve our diabetes management, we can, from this study here, we know that we can reduce the risk of developing some of these complications. So a big study. In 1990, between 1990 and 1997, we started developing insulin pumps. And we're starting to get into the artificial pancreas here. Okay? We'll talk a little bit more about insulin pumps here in a minute. So in 2004, our life expectancy is much better, but it's still not as good as we want it to be. Okay? Those with diabetes, their life expectancy is a little bit less, about 15 years less than those without diabetes. So we want to make that a little bit better. That's one of the reasons why we're doing this diabetes research. So we have these complications. These complications are a big reason why we do diabetes research. So what are the goals of diabetes research? It's to minimize complications and improve the quality of life. It was the driving force in my research and those colleagues of mine that also did diabetes research. Because the goal is we want you to be able to manage your diabetes. We don't want your diabetes to manage you. Okay? And oftentimes it can feel like our diabetes is kind of running our life. Especially when we get to that point where we're having complications, it limits what we can do. So I'll talk a little bit about some of the current diabetes research. We'll talk about the delivery of insulin, and this is primarily looking at type 1 diabetes, but we'll also look at type 2. We'll talk about behavior, the early detection of complications. We'll talk about some genetics. We'll talk about gastric bypass. It's a hot topic right now. And then some of the advances in medications that we're using. So the delivery of insulin, this poor chap here, this talks to the impact that we have on our quality of life. It can be a difficult challenge to manage our diabetes. It requires finger sticks, it requires injections, and it's expensive, as those with diabetes know. So insulin pumps. I've got one up here, and if you want to look at it a little bit later, looks like a little pager, huh? We've got one back here. Very nice. They've really come a long ways. We can actually have insulin, and there's this little catheter here that sits underneath the skin. We'll show you here in the slides, and you can look at these a little bit later. This was the first insulin pump. It's crazy. 1970s. Obviously, this wasn't meant to be worn out around town, but it was the prototype. So we've come a long ways. We've come from this big backpack to this small little pager. And from this pager, in here we've got a reservoir of insulin. And from here we've got this little line here that delivers the insulin to the small catheter that sits just below the skin here and delivers the insulin. So we primarily see these in type 1 diabetes, but the technology is advancing where we're actually able to use it in some of our type 2 diabetics that require insulin. And insulin pumps are actually fairly useful. They can deliver very accurate doses of insulin. And so we can get ideally, we can get very tight control. And we can program these pumps to our lifestyle, and they can react, you know. We know that we have lunch every day at noon, so we're going to need a little bit more insulin at noon. We have dinner at this time, or we don't eat from 10 p.m. until 6 in the morning, so we're going to need less insulin. So these pumps are kind of useful, especially in type 1 diabetes where they depend on the insulin, but it's even useful in type 2 diabetics who are insulin dependent. We actually now have some of these pumps that actually have a little sensor that kind of sits underneath the skin as well. Okay, so in here we've got a sensor that can detect what our blood sugar is, that's talking to our pump, and the pump is delivering the adequate amount of insulin. Now these are fairly new. They're not great. Okay, they're impressive, but you still have to do some finger sticks with these. It doesn't mean you have to stop checking your blood sugar. You have to calibrate all of these. So we don't have an artificial pancreas yet, but we're working on it. Okay, but it's getting closer. One of the other ways we've kind of advanced in our delivery of insulin is that we've come up with insulin pens. So instead of carrying around a vial and a syringe, we actually have these devices that make it a whole lot easier. They're a little bit more discreet. They're useful in patients that have vision problems. They can't see the syringe very well, so that they can't accurately dose themselves. With these pens, some of these pens you can actually click for every unit of insulin you get. And so it's useful in the patients with vision loss because they can actually count the dosage. And the needles that they're using are actually getting relatively small, and so they're definitely more comfortable. So they're useful. Behavior is a big one. Okay, we know what works. We know how to control diabetes. We have medications, and we know all the tools. But behavior sometimes can get in the way. Diet, exercise. Combinations of diet, exercise, and medications. We know that education and support all work. So the ADA has diabetes self-management education. Our diabetes program here at the hospital provides this diabetes education. It's very successful. Okay, we know that this works. Norris et al. Looked at how effective just diabetes education is. Okay, you're going into to talk to a diabetes educator, you're talking to a dietitian, you're talking to a nurse. Okay, and what they were able to find, they did kind of a meta-analysis. They went out there and they looked at all of the studies that have been done, and they picked through them to pick the best studies, the most rigorous studies. And they looked at those rigorous studies and they said, okay, if a person gets diabetes education, how well does it improve their diabetes management? And so we've seen for diabetes education in and of itself can bring your blood sugar, your A1C level down by about 0.75%. Okay, so we're getting close to that 1% decrease in our hemoglobin A1C. And we know with that 1% decrease in our hemoglobin A1C, we greatly reduce our risk for complications. So it is successful. Okay? With that education, we can add on top of that the effectiveness of different medications. And we'll go into that a little bit more as we go along here. But we, in this diabetes education, we give you guys the tools. Okay? We give you the diet, we give you the exercise regime, we talk to you about how to use the medications. But sometimes our motivation gets in the way. And we are human, we're not perfect. And our motivation can kind of follow this line, where we're motivated and then that motivation kind of wanes. And then our motivation rises up and we do a great job and then it wanes. So there's been research, especially to look, and I will talk about a research opportunity here in the Bay Area that's geared towards improving or maintaining that motivation level. So instead of getting these drops, that maybe we can maintain our motivation level right through here, okay, and sustain those improvements that we find with diabetes. So the detection of early detection of complications. And this kind of gets into some of my research, and I won't go into a whole lot more detail with this, but with diabetic eye disease, we know that we can catch complications really early. So my research, here's the eye, okay? Here's the pupil right here. That's the little dark spot in the center of the eye. If we look through this pupil, we look at this tissue here on the back of the eye. And this tissue here is the retina. In that tissue are nerve cells, okay, that turn light into an energy signal that's sent to the brain, and we interpret the world that we see. In that tissue are blood vessels that run through there that feed it and remove waste, okay? Incredibly important for normal vision function is to keep those blood vessels and that nervous tissue nice and healthy. So we can take pictures of the back of the eye, and these blood vessels here, like I said, they feed the back of the eye and they remove waste. In diabetes, we can get leakage from those blood vessels. That means that we're not getting nutrients where it needs to go. And this leaking fluid in and of itself can be toxic to the tissue on the back of the eye. So our goal is to catch problems before we see leaking from these blood vessels. It's called retinopathy. And we want to prevent bleeding like we see here. One way of detecting some of these complications really early is we came up with a technique where we used a special contact lens that sits on the very front of your eye. And this contact lens can measure the electrical signal at the back of the eye, kind of like how we measure the electrical signal from the heart. And that tells us how healthy the heart tissue is. If we look at that tissue on the back of the eye, there's groups of cells, and these groups of cells send an electrical signal, and we can measure that. We can have a person sit here, there's their eye, and they can wear a special contact lens, and they can watch a TV screen that looks like this. Each of these little hexagons that flicker between black and white stimulate the back of the eye. And we can measure the corresponding response on a small patch on the back of the eye. So we were actually able to develop a technique that can catch problems. We can detect some of the neural changes before we see leaking from the blood vessel on the back of the eye. We know that if we get at this early, we can greatly reduce the risk of complications later on. Maybe it's motivation for the patient to improve their diabetes management. Or maybe we need to go from a yearly eye exam to every 6 months. And there's new medications actually on the market to treat some of the leakage from the blood vessels that we see. This is some of the maps here that we can generate. This is kind of normal function on the back of the eye. And then as the disease progresses, we see a decrease in the neural function on the back of the eye. And so we can detect very localized patches of dysfunction, and we know that those small patches are at greater risk for developing leakage. Genetics, because of time, I won't go into this a whole lot. We have genes, and these genes play a big part in who we are. We actually have 23 sets of them. And the goal with diabetes, with genetic research is, again, to see if we can find some genetic markers that can identify a patient who very early on in life that is at greater risk for developing diabetes. Because if we can talk to that patient before they actually develop the diabetes and say you're at greater risk, and if you incorporate, this kind of diet or this kind of exercise or this kind of, follow-ups with your physicians, we can reduce the risk of you actually even developing the disease to begin with. And with type 1 diabetes, they're actually developing some genetic therapies that have had some success with mice models. So it's out there. It's on the horizon. There are genetic markers for type 2 diabetes. We're in the very early stages of some of this genetic research. As the field progresses, we're going to be able to get more and more sensitive with our detecting some of the risk. We're actually pretty good with type 1 diabetes. We know if they have these genes, we find these genes in 90% of patients with type 1 diabetes. So there's a lot of research right now, especially at UCSF, looking at family members of those with type 1 diabetes and looking at their genetic markers and kind of assessing a risk to them and kind of monitoring them and seeing what happens in their life to trigger that type 1 diabetes. One of the other big topics is gastric bypass. Okay? Now, I'm not advocating gastric bypass, okay? But it is a treatment for obesity as well as with diabetes. It's a fairly radical procedure. Here you have your stomach here, and then there's a transition from your stomach into your lower intestines. There's a duodenum, and then there's the jejunum down here. With a gastric bypass, and there's different types, and this is the one I'm going to talk about here. It's the Rowan Y gastric bypass. They actually detach a small piece of the stomach, dissect the jejunum here, and they bring them together, and so they attach the small piece of stomach here to the small intestines. Okay, so they kind of bypass this big portion of the stomach. And then they kind of sew this up here, so you have this pouch, this big stomach pouch, that still is producing some of the digestive enzymes, and it's passing into the small intestines. But then our food here has a much smaller area. Okay, so we're bypassing the stomach. So with gastric bypass, you're eating less food, not because you choose to, but because you don't have room for more food. Okay, but there's other reasons for why this is effective. Some of them we know, and some of them we don't, and they raise some good questions. This particular study here, it just came out in 2012. It's a study where they looked at the effectiveness of gastric bypass versus conventional therapy. And by conventional therapy, it's diabetes education, close monitoring of your blood sugar, adequate medication regimes. And so they followed patients that had this gastric bypass, and they looked at these patients 2 years later. Okay? And 2 years later, 75% of those patients that had the gastric bypass had remission. So what do I mean by remission of diabetes? It means that their A1C went from 8 down to less than 6.5. Okay? They no longer required medication, and their fasting blood sugars were less than 100. So 75% of those patients went into what they call diabetes remission. On average, those patients that had the gastric bypass were able to bring their A1C level down to 6.4 versus those with the conventional therapy, their A1C remained at 7.7. Okay? It wasn't a big change with the conventional therapy group. So we know that it's effective. It raises questions as to why this treatment is so effective. Why, by bypassing the stomach, what is it that that's causing this big change in weight loss as well as with diabetes? It's a fairly radical procedure. There are side effects to it. It is not a pleasant disease. It takes a transition. You still have to change your diet, and you still have to change your lifestyle. Okay? It definitely facilitates it, but it requires some change on your part as well. But the questions that it raises, well, what if we can come up with medications that can mimic this situation? So we don't fully know what it is, what the trigger is, or how this mechanism works. We know that there's less absorption. We know that the insulin sensitivity gets better. We know that the pancreas is able to produce less insulin after these procedures, but we don't necessarily know what the mechanisms are. So there's research out there that's looking at how or what the mechanisms are and seeing if we can recreate that with a medication or some other treatment that's less invasive. Some of the new medications that's looking at the stomach and the intestines. Some people here in the audience may actually be on these medications, Byetta and Januvia. They work on a hormone that's produced in the stomach, and this hormone is called incretin, or GLP-1, and this hormone is produced after you start to eat, okay? And it triggers the pancreas to produce more insulin, and it also works on your liver to reduce another hormone that can kind of complicate the situation. So we have medications. So we like this incretin, we like this GLP, okay? So we want more of that, okay? So we have medications that will increase the amount of this incretin as well as prevent it from getting broken down, because this doesn't last for very long, okay? After a while it gets broken down. So both of these medications work on this system, and they use these in conjunction with other medications, and they're fairly successful, okay? They can bring your A1C down by about 1%, okay, in conjunction with other medications. So Januvia is a pill, and Byetta is an injectable medication, the same way you would have like an insulin pen, a similar kind of a method of injection. So we've talked about some of the different recent research that's going on. There's actually some opportunities here in the Bay Area for you to participate in research. So, and I want you to encourage you, because there are some advantages to participating in research. Some of this is you get access to some very cutting-edge treatments. You get access to expert opinions, some cutting-edge diagnostic tools. And it's interesting, and you get to contribute to the future. So I want to encourage you to participate. Along with that, though, you need to kind of know what you're getting into. So I'm going to talk a little bit about that. So the challenge to research is that it can take a little bit of time, okay? And you always need to think about safety. You want to know what you're getting into. You want to know how you're going to be protected. Here at Washington Hospital, we do research. And at every institution that does research, there's an institutional review board. And this board of people, it's composed of doctors and nurses and community members, and their job is to protect you, the participant. So every research scientist has to go through these IRBs, and they have to, they have to be able to make a case that they're going to, whatever they're going to do is going to be safe, and that they're going to protect the participants. So know that if you do participate, that this researcher has had to go through these committees, okay? And they're fairly rigorous. They make, researchers aren't big fans of them just because it requires a lot of work, but they're incredibly important, okay? The FDA also works hard to protect the participants in research as well. So what are the risks? These are some of the things you need to know. You need to make sure they have informed consent. When they sit down and they talk to you about the research study, they need to take the time to make sure you understand what you're getting into. That's what we mean by informed consent. And you also need to include your primary care physician. Some of these research studies, whether it's a medication or an early diagnostic treatment, it's important to let your doctor know so he can kind of advise you as well. Some of these things may interfere with your current treatment. So you want to make sure you include him in the decision process. If you are going to participate in a drug trial, there's different stages to drug trials. Stage 1, Stage 2, Stage 3, and Stage 4. Stage 1 is the first one. It has the greatest risk. That's the first test on humans. Stage 2, they look at effectiveness versus a placebo or a sugar pill. Stage 3, they compare medications to other medications or other treatments to see how effective they are. And then stage 4, it's kind of a long-term looking at some of the side effects. So if you're going to participate in drug trials, the safest place to get in is stage 3. So ask about that. If you do decide to do a clinical trial, get in here. There's less risk there. Okay? It all depends. So if you do decide to participate in research, and I'm going to talk about some opportunities here in the Bay Area, this is a list of questions that you should take along with you. And all of these questions should be able to be answered when you sit down with a scientist. Okay? I won't go over these. You have these with you here. So some of the research opportunities in the Bay Area. UCSF is looking at the Paleolithic diet. I was back on the East Coast at the Smithsonian, and I was talking to this gentleman here, and he was giving me some advice on my diet. There's some data to suggest that the Paleolithic diet can actually improve our diabetes management. So at UCSF, there's actually a study. Participants receive 3 weeks of meals, test for their insulin resistance, and they check their cholesterol. They'll follow patients for 2 months, and you get compensated. There's no charge for the food, and you get compensated for your time and energy. Look into it. If you have questions or interested, you can contact this person here. Diabetes support. When I talk about the behavior and the motivation fluctuating up and down, this study here is actually looking at how we can improve that motivation and actually maintain adequate diabetes management for the remainder of your life to actually minimize some of those risks. This one here actually requires no clinical visits. And so it's all over the phone, and they also compensate you for your time. There's a study that I've been involved with at UC Berkeley, and if you're interested in that, you can talk to Marilyn Sneck. If you do decide to participate in research, it is a commitment, and these researchers are depending on you. So if you decide to participate, try as best you can to follow through with it. Okay? The data is depending upon you, and one of our biggest challenges in research is actually getting participants and keeping them involved in the study from start to finish. So if you do decide to participate, and I encourage you to do so, try and follow through with that. So I'm not going to summarize because I think we're out of time. I want to thank you for your time, and I want you to know that there are people out there that are looking at diabetes, and they're trying to improve your quality of life. They're trying to make things easier. And that's it.